Hi, I'm Ethel, and we're from Group 24, and we'll be doing our presentation on mixed cranial nerves and their palsies. So by mixed cranial nerves, we mean nerves that have both motor and sensory functions. These are cranial nerves 5, the trigeminal nerve, cranial nerve 7, the facial nerve, and cranial nerve 9, the glossopharyngeal nerve, also cranial nerve 10, the vagus nerve. So the trigeminal nerve gives off 3 branches. The first branch is the ophthalmic nerve, and it exits the cranium at the superior orbital fissure. The second branch is the maxillary, and it exits at the foramen rotundum. And the last branch is the mandibular, and it exits at the foramen ovale. As we go through the sensory innervation, we actually encourage you to trace the innervation on your own faces. Okay, so the ophthalmic will provide sensory to the forehead and the scalp. It will also provide to the frontal and ethmoid sinuses, as well as the upper lid and conjunctiva. It will also provide sensory to the cornea and dorsum of the nose. The maxillary nerve provides sensory to the lower eyelid and conjunctiva, the cheeks, the maxillary sinus, the nasal cavity, lateral nose, upper lip, the teeth and their gingiva, as well as the superior palate. Lastly, the mandibular nerve has sensory to the floor of the oral cavity, to the external ear, the lower lip, the chin, and it provides general sensation to the anterior 2/3 of the tongue, as well as the lower teeth and gingiva. In general, a palsy would appear as a loss of sensation over affected area and weakness of jaw clenching and side-to-side movement, because the mandibular branch also has motor innervation to the anterior belly of the digastric and to the muscles of mastication, such as the masseter, temporalis, and also the median lateral pterygoids. Okay. So in trigeminal neuralgia, there'd be a unilateral pain in the distribution of the nerve. Pain is episodic with sudden onset, lasting a few seconds to a few minutes, but then stopping suddenly. The patients may go into remission for a few weeks, but unfortunately, the pain-free intervals gradually shorten. With lower motor neuron lesion, the presentation would be the jaw deviating to the side of the weakness. Okay. So the greater petrosal nerve, the nerve to stapedius, and the chorda tympani are considered intracranial, while the posterior auricular, nerve to digastric, nerve to stylohyoid, and the 5 terminal branches are considered extracranial. Using the diagram of those terminal branches to the muscles of facial expression, the branch that's labeled number 1 is a temporal branch. It innervates the frontalis and the orbicularis oculi. Number 2 is the zygomatic branch. It innervates the orbicularis oculi. Number 3 is the buccal branch. It is responsible for the orbicularis oris, the buccinator, and the zygomaticus. Number 4 is the marginal mandibular branch. It innervates the mentalis, the depressor labii inferioris, and the depressor anguli oris. And lastly, number 5 is the cervical branch. It innervates the platysma and the depressor anguli oris. Okay. So an intracranial lesion would result in reduced salivation from the submandibular and sublingual gland. Also, due to the chorda tympani, you'd have loss of taste on the anterior 2/3 of the tongue, on the ipsilateral side. You would have hypersensitivity to sound on the same side of the lesion. This is due to the nerve to the stapedius. And you'd also have reduced lacrimal fluid secretion because of the greater petrosal nerve. This can be because of any middle ear pathology, such as inflammation or malignancy. An extracranial lesion would result in facial paralysis only, and it can be because of a parotid gland tumors or parotitis. Infections by herpes virus, such as varicella zoster virus and Epstein-Barr virus, can also cause this facial paralysis. When the cause is unknown, it's called Bell's palsy.
Okay, so we're now going to cranial nerve 9, which is a glossopharyngeal nerve, sorry, and there's, as you can see, lots of branches from it. They're all sensory apart from the nerve to stylopharyngeus. So the tympanic branch enters the middle ear and gives sensory innervation to the middle ear, the internal surface of the tympanic membrane, and the eustachian tube. The carotid sinus nerve goes to the carotid sinus and carotid body and provides feedback from the chemoreceptors and the baroreceptors there. The pharyngeal branches give sensory innervation to the pharyngeal mucus. The lingual branch is to the posterior third of the tongue with taste and general sensation, and the tonsillar branch is to the tonsils. And then the nerve to stylopharyngeus, as I said, is a motor nerve and elevates the larynx and dilates the pharynx to allow swallowing. Wernicke syndrome is damage, or Wernicke syndrome is also known as jugular foramen syndrome. It's because it's damage during the passage of the nerves through the jugular foramen, which are cranial nerve 9, 10 and 11. The effects from cranial nerve 9 itself are loss of sensory function from the posterior third of the tongue and loss of the gag reflex due to impairance of the sensory innervation to the pharynx. Cranial nerve 10, the vagus nerve, has a fair few branches as well. The auricular nerve is sensory innervation to the outer ear. The pharyngeal nerve is motor innervation to the majority muscles of the pharynx and soft palate. Superior laryngeal nerve splits and becomes external and internal. The external is the cricothyroid muscle, and the internal gives sensory innervation to the laryngopharynx and other parts of the larynx. Sorry for running over. Okay, I'm going to have to. The other important one here is the thoracic cardiac branches and the cervical cardiac branches innervate and regulate heart rate, and also give visceral sensation to the heart. Palsies of cranial nerve 10 are quite rare, but they can have quite adverse effects. The cardiac changes can cause palpitations and increased heart rate due to the lack of parasympathetic innervation. Vocal changes are caused by palsies of the recurrent laryngeal nerve, which can be dysphonia if it's unilateral or aphonia if it's bilateral. Stridor, which is a high-pitched breathing noise if it's bilateral due to the air moving through a narrower gap of the vocal cords. And dysarthria, which is the problem of articulation. It can also cause dysphagia, alveolar deviation away from the side of the palsy, and the loss of gag reflex, this time due to lack of motor innervation to the muscles of swallowing. Thank you.